we had more than one lecturer talk to us about the hyoid. What bone does the hyoid attach to?
Nothing.
To the nothing bone, correct. The hyoid doesn't attach to any bone, it's free floating. Well, so what's its purpose? It's just a focus of attachment for muscles to sling around it. Okay, so you have muscles that's directly attached to the skull, to the jaw, down into the chest. One little tiny, I'm losing my word. It's got two bellies. Is that bipinnate? Bipinnate. Is that bipinnate? Yeah, one bipinnate muscle, the omohyoid muscle that goes down into the shoulder. In dissection, this is like a tiny little muscle. So we had teachers lecture to us about all the shoulder cases that they cracked because it was the hyoid bone was restricting the shoulder. To which my answer is, really? As a student, it was like, As a doctor, it's like, yeah, really? No, this is standing up and talking about it and looking at something in an anatomy book and making this connection to a shoulder problem connected to this itty-bitty muscle. Is that possible to have such a clinical case? Yes, it's possible. Is it likely? No. And in our world of treatment, it's Occam's razor. The most likely explanation is probably what it is. Your shoulder problems probably involve either some big shoulder muscles or some organs nearby. That's what it mostly is most of the time. And we say that when we hear and then there's that. So we say when we hear hooves, it's usually a horse, not a zebra. Sometimes it is a zebra. But we learned a lot of things, and I've been in a lot of courses where the zebras were presented as though that's what was your normal practice was. And my regular practice, I end up seeing a lot of strange things, so I do see a lot of zebras. But so I just don't do it. I want to show it to you because I don't want to edit it out. We had things edited out for us in school. If the teachers didn't like cranial, we wouldn't learn much from them because they didn't like it or they didn't believe in it. It became very much that way. If they liked, cracking, you learned cracking. And so many different schools and universities that I've taught at, they all have their focus, and the focus depends on who's in the department, not even the building. It depends on who's there. So for cranial, what I'm trying to do is to show you as much as I can what everybody else thinks, and just give you the backup of my own clinical thoughts. We're not doing this weekend intraoral stuff, but these muscles here above the hyoid, at least the hyoid is something you can do for this intraoral tension. Intraoral release is great. It falls into that smaller category. You're not doing intraoral stuff and you somehow haven't done a vault release. So while the other techniques, I don't like to use the word advanced, but they're things you would learn after you do the vault. If you don't know how to do the vault well, there's not a point in doing the other stuff. And most of what I'm doing most of the time is this basic stuff. But there are a lot of nice releases that can be done for these muscles here individually. And we can start to relate things regionally. You've heard me talk about local, regional, and global. Certainly there's regional implications for anything you're doing here along the neck because there's so much innervation. It is really difficult to connect people's clinical symptoms necessarily after they've been to a lot of practitioners. Do you suddenly know why that is? I got this problem here and that problem. I can try and think about it, but all you have to do is have some irritation here, grab some nerve here, and have the information go up or down. And a lot of times it just becomes areas of gray. I'm not going to think about why that is. And so it's much easier for me to do treatment by not thinking and just going from head to toe and treating what feels restricted to me. Not at all based on their story. If they tell you, my neck hurts here, and you evaluate these muscles and they all feel normal to you, if you're somebody who does a lot of muscle work and the muscles feel normal, do you expect to get a benefit by treating those muscles? I mean, do you really? And I'm not blaming you because I learned in a similar, this is the way things are taught, that were taught to me. For neck problems, stretch the scalenes out, do this and do that. But if we're not doing a technique, do this technique for neck problem. If someone says, I have this pain right here and they're touching their scalenes, and then you feel their scalenes and they feel supple to you, do you expect it to change by stretching their scalenes? I wouldn't. So you have to have some other way to find illness in their body. Restriction, that's what it is. That's what it is. Any questions so far on that?
And you said for kids you're doing the vault and the sacrum, that's it more?
Hold on. For children, let me just bring this up here? I can't. There we go. For children, I am at their sacrum, and then I do some visceral things to their gut, because their diaphragm is they're brand new. Even the ones that are pretty tragic, their gut is pretty. It's supple. That the restrictions are right in your face with children. Children have simple problems. What are the problems with babies? The simple problems with babies. What is it?
Colic.
Colic. Who here is a parent? Yeah, if your kid's not sleeping, neither are you. Okay? And if you go to the doctor and the doctor says you have a normal child, you just have a colicky baby, that doesn't make you feel any better. Okay? A baby has only one way to voice its opinion. So a baby has to eat, drink, poop, pee, and God willing sleep. So if there's anything wrong with that machinery, which is brand new for a baby, when you have indigestion, you can deal with it. You go, I ate something bad, and that's just why I feel bad. A baby can only carry on. So if there isn't anything that's immediately life-threatening, that baby has some irritation. And the doctor may say, well, it's just normal day. That normal means they're a healthy baby otherwise. And colicky babies are some of the simplest things to treat, and digestive things. I don't know if that answered the question. I don't remember what the question was.
If you did the vault and sacrum, basically.
Yeah, vault and sacrum, and then I do things to their abdomen, but not the diaphragm release the same way. There isn't the need. You can just go right and touch their GI tract and do some releases that way. You can't be sleeping yet. We're not done. It's warm in here.
Processing it.
Oh, you're processing, all right.
Yeah, you said the vault.
No problem, you're processing. Other questions?
You don't have to think about it.
Other questions?
Deal with that.
No other questions? All right, let's look at the next one. Let's look more in deep at this mechanical model. Now we're going to start to talk about the vault, and the rest of this weekend we'll be looking at the individual bones and putting all this treatment together. The diaphragms, for me the diaphragms are something I'm doing quickly. As I said, 30 seconds, I'm done. In the whole cranial treatment, the sacrum is important. According to that theory, the vault is important. That's the whole point of craniosacral treatment. I like to do something that I can do in the middle for the rest of that person. This whole model you can think of as these gears. No matter whether it's a biodynamic model, whether it's a membranous model, bony model, they're all based on one thing clicks and another thing clicks and another thing moves. Our theory is that single bones go through flexion and extension, and paired bones go through internal and external rotation. This is a sagittal view, just the same way I'm standing here. This is the base. This is the occipital bone here. Okay, this is the base of the occiput. This is the base of the sphenoid. That's not what we're touching. What we're touching is the greater wing of the sphenoid. On the let me have the skull. This is inside the mouth. These plates, you're not going to touch that, not in this weekend. And this is the ethmoid bone. In front of this is Crista Galli. This is your nasion, your forehead, your nose coming out this way. Okay. So what we're saying is all right. Let's just do this. There we go. Oh, this is great. I got one, but it doesn't have the magnets. Got little pegs. This is much better. This is what we're saying. The base of the sphenoid, base of the occiput, that is rising up. And this is what you're feeling. If this is the same way that I'm standing here, this is why we say the fingers go down to the ground. Because you have a finger on the greater wing of the sphenoid and you have a finger on the occipital bone. And if we make this a wheel, this is a wheel and this is a wheel, then as this part of the wheel rises up, the other part is going down. As this part rises up, the other part comes down. Okay. Single bones going through flexion and extension, pair bones through internal and external rotation. These are happening together. When flexion is happening, so is external rotation. When internal rotations, when extension is happening, internal rotation is happening. It's not one than the other. This is what we're trying to show, or this is what we theorize. This isn't measured, to my knowledge, in any credible study, but that there's a tension in the dura, where the dura is shortening from front to back, okay? And in a small amount, that diameter is changing, which means this diameter has to become slightly wider. The best thought in my mind is that the skull is changing its shape a little bit. It is not getting bigger or smaller. My reason for just choosing to believe that theory is if it were getting bigger and smaller, your brain doesn't like tension. If we touch your brain, touch your brain tissue somewhere, we get a focal neurologic deficit. Your brain generally doesn't like being touched. Okay, so this is where we're getting that sensation of when I say we had to learn things, which we will get to by our last day with flexion, extension, and doing our different diagnoses by hand twists, that this is the sensation of this model being just this way, going through flexion, extension, flexion, extension. So that's down to the feet. Whoop, one of your magnets just came out.
It's mine.
Oh, it's yours?
Yeah, it's mine.
Oh, yeah, there you go.
Uh-oh.
Nothing crazy glue can't fix. Nothing crazy glue, duct tape, and a hammer can't fix. Okay, so that's flexion, that's extension. This is that other hold you'll see people talk about. I completely skipped it with you. In the interest of time, I'm editing it out. It's something you'll learn that'll be uncomfortable for most of you, having their head on your hand. And you also cannot reach. Gahan's showing you in this diagram that they're reaching over and grabbing both parts of the head. You won't be able to do it on most of the people in this room. You'll only be on part of their head. So it's not it's a hold, not a very good hold. Okay, so after all that ado, let's look at the cranium. Our friend the occiput. When they're laying on the table, their head is bearing into the table like this. That's why I said you need to be back. If you want to sense what's going on in the occiput, you need to be back on the occipital squama, which means you have to be beyond the mastoid suture. This part you're not seeing, that's the inside of the skull. Okay, that's where it's meeting with the sphenoid. There's a lot in our osteopathic books about different lesions and different problems and trying to relate them to different areas in the brainstem. And they will relate them to do this type of treatment. It's an occipital problem because it's something coming off the brainstem. But I want to say that to you, but I want to tell you that's not a practical way to look at it. Okay, we can go through all the different cranial nerves that are coming off the brainstem, but every digestion problem is not an occipital problem. If you go on the occiput and it feels normal to you, then you're going to go to the next bone and the next bone and the next bone. Do you have a question, Pat? Okay. It looks like you're in motion to do that. So the quickest way to do this will be to do a protocol, by protocol meaning that you'll examine each one of the cranial bones quickly and see if you can get some mobility. If you get mobility, then you move on. I want to revisit sacrum again. This is a blown up view of what we say is happening at the sacrum. There's a thick attachment to the dura at S2. It does go all the way down to the filum terminale. At the same time that flexion is happening, the sacrum is also being pulled up a little bit. Okay, so now the motion is a little more complicated than we were talking about. We said the sacrum is going back during the flexion phase, but it's going back because it is getting pulled up by this connection at S2. That's the cranial theory. Okay, so it's not just that you're feeling it going back, you're feeling it going back and going cephalad. We're going to use that. This is a bit redundant because we've already talked about it. We're saying that the sacrum is doing this, it's going back, and at the same time it's going up. We can try and relate that to anything in that region in the pelvis. We can relate it to pelvic problems, incontinent type of problems. I'm trying to walk a tightrope of giving you things that I've heard, do this treatment for that, versus putting it into a protocol and evaluating everything from beginning to end. If this is what's happening with the dura, that this is being pulled up, the dura is being pulled up, the AP diameter is shortening and the sacral base is coming back, then we can do another motion to try and get a cranial release. A very nice one if you can feel it. And this does require you to feel rhythm. If you can't feel the rhythm, this doesn't make any sense. We're going to spend a little bit of time with this. This I do sometimes. I do it when I happen to think of it. We call it rocking the dural tube or dural tube. You're going to put a hand on the lumbosacral junction close to the sacral base, and you're going to put a hand under the neck. So a flexion extension is happening, and the skull is doing this, and the sacral base is going back. It's also going up and down at the same time. How will you know that's going up and down and it's a cranial rhythm? How will you know? It'll be slow. It'll be a cranial rate. That's how you'll know. None of this is more difficult to feel, by the way. It's going to seem really awkward when we do this technique, which we're going to do in just a minute. None of it is more difficult if your patient is big, small, old, young, baby, screaming, crying, yelling, biting you at the same time. None of it is more difficult to feel. It's just in your mind that you may think it's more difficult to feel through all their clothing, through all their tissue. It's not. So during the craniosacral flexion, this comes back, this goes forward, this comes back. But what we're going to try and palpate is this tube coming up. So what we're going to try and do is feel it and increase it a little bit. That's an idea we're going to get into, inducing the rhythm. We're going to make a hyper jump, and we're going to believe something, and that is that increased cranial amplitude is increased vitality. I have no science to prove that to you. Let's just say that you have a cranial rhythm, and if we can make it bigger and stronger, not faster, but bigger and stronger, that this will be more healthful for your body. And that's a really weak thing to say medically, but this is part of what I do. Releasing restrictions and getting body's normal processes to become louder in your feeling. What I want you to do, the time to do this is to go back with your patients where you're not stressed and they're not eyeballing you, asking you what you're doing. Oh, what are you doing, Pat? You know, nothing. You just do whatever it is you normally do. And if you're put needles in them, stop for a few minutes and just evaluate. What are you doing? I'm just feeling what I feel, the energy in your needle. You can say whatever you want. It's for you to study. People don't want to, patients would be frightened to know this, but we say in medicine, see one, do one, teach one. Every surgeon had the first surgery they did by themselves, and the patient had no idea that it was their first time alone. I'm going to do this hand first because it's a little hard for me to get in. I'm just going to go close to her sacral base. Okay, I don't have to be on it. And I'm going to go underneath her neck. And you have to relax. What is the motion that you should feel here? It is up and down together. For me, it is just like turning on the radio and you hear a song. You start to hear a snippet of a song. In order to do this technique, you have to feel something. My hands are going down towards her feet. Now they're coming up towards her head. First, you have to feel it. Now they're coming down towards her feet. If you're able to feel it, now can we make it do it more? We can. Now it's going back to her head. We can increase the amplitude, the excursion through which it does by following it. And at the end of its motion, you're going to hold it. Well, how am I holding it? I'm barely using any force. It is absolutely, I don't care what anyone tells you, it is a mental connection you have with them that we're going to go a little further. And there's some slight change in my physical force, but this is not a physical thing. It's not pushing it into flexion or pushing it into some sort of rotation. It's just like I'm sailing along, singing a song. Actually, you don't want me to sing. It will not be therapeutic for you. Although in the car, if it's up very loud, I sound just like Frank Sinatra. If it's very loud. If he's louder than me, I sound just like him. Anybody who doesn't like Frank Sinatra doesn't like home cooking. This is New York. You have to love Frank Sinatra here. It's not like a requirement.
Yeah,
Oh my
no one
God.
does anymore.
I told my kids from all the junk that they listen to, said 100 years from now they'll only remember three singing entities. Francis Albert, the Beatles, and of course Elvis Presley.
Most people know Michael Jackson also.
Maybe you're right, but I don't think he'll be known over, like if they look back in history 100 years. It definitely won't be the Spice Girls, U2, Snoop Doggy Dogg, or any of the stuff that has been bombarded through my ears, through my house for many years. This should feel either very pleasant to your patient, your partner, or nothing. When you do rhythmic things, you can get lost in this and spend a lot of time. I do this sometimes. I do it sometimes. I don't want to tell you a condition I do this for. This is not. This is a general whole body wellness is what we're saying we can do a cranial protocol for. Is this for a gastric thing because I have my hand on her low back, and a neck pain because I have my hand on her head? No, it doesn't work like that. In order to do this, you have to connect with her. You have to be with her. In order to be with her, you can't be thinking about her. You can't be thinking about you. The rhythmic stuff is great. I do mobility and I do it quick. That's the only way I go very quickly with babies and all. And I spend a little bit of time doing things like this because only a little bit of time is needed. Except for, as I said, I do have patients that just have too much money. They don't know what to do with it. So then we can do any crazy thing you want to do. Okay, because their problems are a hangnail and mostly psychological. So we can sit here and get lost in this and do this. But I got to fix something physical that's there. I don't mean that psychological is not important, by the way. Your psychology is you. But when all the rules are off because they really don't have these issues that they're talking about, they just have this drama. This is a good way to play out that drama and let them get some release. So I'd like you to get someone on the table and try this and see if you can feel something. Get your hands comfortable. Go in both lordosis. I go close to the sacral base. You got to get your hand comfortable in the neck. Okay, and it is down together and up together. See if you can feel something. I'll come around. I'll do it to as many of you as I can. This should feel pleasant.
Reach the end of the amplitude. Use the mental idea.